You can hear me, right?
Yeah, I can hear you.
All right, good. Chris, thank you very much. This is a beautiful venue. Holy smokes, gorgeous. So thank you very much. And thank you all for taking time out to come. This is, well, I will just dive right into it. For whatever reason now, we're the belle of the ball. And probably the best objective evidence of that is the amount of papers that are being generated, and then the amount of money that's going at it. So not exactly sure where the reasons are, but what we're going to do tonight is we're going to zero in on one particular aspect of lung cancer care, and that is early lung cancer detection. This talk is primarily targeting a surgical group, and that's surgical disease, early lung cancer. No, go back just a second. Nodule management is really the other side of early lung cancer detection, because that's how early lung cancer presents, as nodules, lung nodules. Go ahead. So we're going to take a look at that, and there are several forces that we're kind of going to be aware of as we're talking about it. The first is the ethical force behind why we should worry about early lung cancer detection. And we all know these statistics. 5-year survival is better the earlier you find. You just heard Justin just talking about that. Next slide. And we also know this statistic, that most of the majority of cancers brought to the clinician today are actually advanced stage. So that's the ethical force of view. We're driving toward getting early lung cancer detected because it's the right thing to do for patients. There's also a professional force, and this is the surgeons talking. There's about 200,000+ cases of lung cancer per year. Only about a third of those, at the most, are in early stage in surgical disease. Over the next 10 years, we're going to see a significant increase in caseload per surgeon based on population growth and aging. That's if we stay at the current stage of detection. Plus, we're going to see increased penetration with lung cancer screening. So there's a professional force that's going to be pushing early lung cancer and therapies associated with it. Next. And there's also a business force. The margin on cancer in general is 2 to 6%. These two articles, to me, were very interesting because one of them looked at the average revenue associated with a bronchoscopic procedure at $35,000, and JCTVS followed 111 lung cancer patients through the way, and they had a 33% operating margin. So obviously, there's some money to be made, which is going to be driving this, not that that's the end-all be-all. So, but there's also a wild card in this game, and that is 1.6 million incidental nodules are discovered every year. And that's at the current detection rate, which is not exactly airtight. These have a malignancy rate of anywhere from 1 to 6%, depending on the study you read. Historically, these have kind of been ignored is probably a strong word, but certainly pushed over in the corner, because if you didn't do anything about them, 90+% of the time it'd be okay. So, but I don't think that paradigm is going to last. In fact, I know it's not going to. Ethically, legally, financially, hospital systems are going, we can't afford to run the risk of missing something, getting sued for it. So if you step out for a second and go, okay, driving early lung cancer detection or nodule management, there's an ethical force, there's a professional force, there's a business force, and there's a massive pathology there. So that's a very significant thing coming down the pike. But the issue we have is informing that are very cumbersome communication and classification tools. You can go next. And what do I mean by that? Well, when we talk about lung cancer, these are the schemes we use to talk about them currently. On the left is Fleischner, and on the right is Lung-RADS. I don't think anybody would call this simple or effective. It's very, very cumbersome. So, next slide. So, how in the current state of affairs do hospital systems address this? Well, administration and MD get together. There's usually a champion, an administrative MD or administration champion or a physician champion to put together the parts of a program, to arrange clinics, budget, and so on. Typically, incidentals and intentionals, low-dose CAT scans, are handled separately. The PCPs are tasked to screen people, and that generally has not been tremendously successful. There's kind of a plateau on that, primarily because these folks are not reimbursed for it at this present time. Marketing is tasked with making everybody aware of this. Again, not generally successful. You have to hire people to manage around there. And then there's always the question of acquiring technology. There's operating room technology, there's bronchoscopic stuff, so on and so forth. So the problems you run into when you approach it this way are the decisions you're having to make about programs are typically based on projections. It's almost data free to some degree. And the expenditures that are required, which are technology and FTEs, are expensive. So in addition, no hospital system wants to enter into detection strategy purposes. If you are airtight and you're generating all these nodules and all the data around them, how are you going to manage that data? Going back to our communication tools, what in the world how are we going to talk about these things? Because the current system we have is not tremendously effective. How are you going to triage the low incidence nodule that is probably not a malignancy versus the one that is a high risk malignancy? How are you going to do that? And lastly, these things all together generate a process that is very slow and typically slow to mature. Now, generating a sense like what you just pictured there, kind of drowning in the whole process. Sorry, go ahead. So at TriHealth, which is where I work now, this is our program. Now it's been about a dozen years in the making. I took the job in 2019 here because parts of this were in place and we saw the vision for the future. But we started off in general with this centerpiece here, which almost every hospital system has. Those are your providers, those are your clinics, and so on and so forth. About 6 or 7 years ago, we developed the early detection team, which is responsible for lung screening, incidentals, and the clinics and stuff associated with that. And about 3 years ago, we added the patient experience team, which is really a group of navigators that helps folks navigate this system of care and information and so on. Next. This is the program that we have now is composed of 44 providers and the staff, and it includes all the things listed there. We handle about 500 new patients a year. From a nodule standpoint, we're looking at 5,000 to 6,000 of them per year, and they're broken down about 4/5 of those are incidentals, and the rest are intentional low-dose CAT scans. But that's a lot of nodules. And even though a low percentage, relatively speaking, are malignancy, they still have to be evaluated. They still have to at least have the initial decision, this is a concern or not. Next. So in general, I would describe us as robust and successful. This is our lung screening volume and development. So last year we did 5,685 screenings. The red arrows are points at which we've added FTEs or done significant personnel changes to be successful. Next slide. Another way to represent that, you can see we've had annual growth in the number of scans provided. Next. Annual growth in the number of referrals to lung nodule. And this is our staging. This is what we're trying to accomplish, right? We're trying to shift the curve toward early stage cancer. One more time. The reasoning I'm zeroing on this is because I want to talk about the surgical volume, which is really, again, this was targeted at a thoracic surgery audience. This is roughly my surgical volume path, or surgical volume curve over the last couple of years. When I first came to, nope, not yet. When I first came to Cincinnati the year before I came, there were 67 resections done for lung cancer. This year will probably be 225. So we've seen with the efforts around that system a significant growth. Okay, now. With the exception of this period here, this was late 2023 and early 2024, and for some reason or other, next, we saw a drop off in not only surgical but diagnostic volume. I still don't have an explanation for that, but it was fairly prolonged. It lasted about 6 or 8 weeks. We also had pulmonary recruitment that was stagnant, and I was looking down the barrel of the primary referring pulmonologist getting to retire. At about the same time, we kind of had it up to here with frustrations with low-dose CAT scans and trying to move that forward. Although the number of scans were increasing, the baselines, which is an index of PCP engagement, were actually dropping off. So we couldn't get the PCPs on board. Marketing didn't seem to get the picture. Our FTEs were maxed out. Compliance was giving us issues about not being able to look at incidentals because we weren't involved in their pathway. The electronic medical record for getting the smoking history accurate was problematic because that triggers the BPA. And then the straw that broke the camel's back, we discovered that for every 100 low-dose CAT scans ordered, 40 of them got scheduled and completed. That was it. Because motivational issues with PCPs, time, no schedulers, and so on. So one more slide. We also were seeing an increasing number of incidentals because of increased attention being paid to that. And this was one individual that was doing this in her off time. We couldn't get radiology or pulmonary. Nobody wanted to own these things. So we kind of had reached a point of we were as big as we were going to get with what we had to work with. So we started looking at alternatives. We looked for nodule detection software that would somehow detect these nodules, take this burden of work off of this individual and streamline them. Very expensive, 150 grand or greater. And the obvious question there is if you start finding them, how are you going to manage this? So we talked to a number of companies that do data management. equally expensive. So we went back to the hospital and said, well, we can do this, but we need more people and money. And it was a very polite but very firm no money to be had. So about this time, I met Ryan through one of my partners. Ryan had been an ER doc, still is an ER doc, but had committed a bunch of his time to working with RevealDX, which was an artificial intelligence nodule characterization system, proprietary technology. And what impressed me from the beginning was it was educated upon the National Lung Cancer Screening Trial. So in other words, all the data around those 56,000 patients were used to make this brain. As much as I understood this statement that a nodule wasn't just another look at the image, it was actually converted into some astronomical amount of points analysis. It generated a single number, not a stack of numbers in 4A and 4B and 6Q and whatever. It was a single number, an MSI. It occurred at the point of nodule detection. The data suggested increased accuracy. It was reimbursable, which was key. But although it was not FDA, it was in the process of being submitted. So, next. So, got to thinking about this. Next. We looked at detection. Now we had a stratification possibility, and we had a management scheme, and we had the ability for the stratification system to pay for the other two. So this made a ton of sense. It's like, okay, wait, this might work. So, next slide. This is the way we envisioned it. It wasn't linear, really. It's more interactive because you detect, that informs your stratification on into your tracking, your stratification. It's a circular interrelationship. So, talked a lot about this. Next. And we went back to some of the vendors that we talked to at the detection and the tracking side, and they were very interested in making this and putting this together. So we started. ClearRead is the actual product. RiverRain is the company. ClearRead is the product. It subtracts out the vascular and other interfering structures. It provides expanded data, in other words, the volume and the comparison data. And we expanded the application to everything that had any imaging of the lung whatsoever. Next. This is a quick view of what you get. These are the thumbnails that appear at the top of your PACS read, and they automatically populate. The radiologist has to do nothing to make this work, which was a key selling point. Click. This is the image that, with a subtraction in place, and you can see the nodule. That's one nodule that's been detected. Click it again, if you would, please. This is a closer look at this. Different nodule, obviously. Oh, nope, go back. And then there's volumetric data, which surprisingly is becoming our standard of communication about size. It's much more reliable within the radiology literature in terms of predictors of true growth. Next. Also automatically populated into this report is any comparison data. So if the patient has had a previous study, it's pulled in by this program. So it becomes much easier, and you can see, click on it just a second, I forget if I highlighted it. Here's an example. You can see comparative data. So it becomes much easier to talk about, okay, how has this changed, since obviously that's a very significant component of this. Next. Once the MSI is approved, this will become part of this report. It will be automatically triggered by just the presence of a nodule. Next. So how does it work? It was installed in December, took about a month to fully integrate. In Q1 2024, a year ago, 11.8 incidentals a day. I'm sorry. No, that's correct. Incidentals per day. This year, 22.8 incidentals per day. Huge, huge difference. The threshold has been set at 3 millimeters. Radiology has that. And surprisingly, and I think as much to their surprise as everybody else's, the radiologists love it because, next, it runs in the background. They don't have to do anything, but they're better at what they're doing. So that's the detection side. The management side, Reveal, as we talked about, it generates an MSI. It will run in the background, automatically triggered by the presence of a nodule. That's once it's FDA approved. It occurs at the point of nodule, or will occur at the point of nodule. It will be included in the notifications provided to the radiologist, so it'll help inform their decision. It will also be a component of what helps to decide the tracking of these particular individuals, and will obviously inform interventions. Under the current system, what we're doing is all low-dose CAT scan in our system that have a nodule detected go through a lung screening program. So there's a built-in control. It's a review by a group of pulmonologists and surgeons and so on. What we've done now is we consent those patients prior to they're getting a scan. If they have a nodule, that nodule is put into a special server that is accessed by Reveal and one individual within our system. That person then undergoes the control evaluation, if you will. At the end of the period of time that they're being evaluated in that lung nodule screening clinic, the MSI is revealed, if you will, and then the impact on potential pathways evaluated. So it's a way of taking the system we have, control, and assessing the clinical impact of this information. Does that make sense? Okay. Reveal. MSI is a number from 0.1 to 0.99, 0.99 being essentially the diagnostic of cancer or highly sensitive for it, 0.1 being suggestive of a benign condition. Next. As pictured here, it flows directly through the radiologist workflow. According to this slide, there will be a click involved that with integration of Riverain and Reveal, that won't be necessary. Next. Go ahead and click it one more time. This is one of the summary of the validation studies. 5 studies, 1,530 patients. And what I want you to really focus on here is this. This isn't the sensitivity and specificity. These are the number of patients in a retrospective analysis, if the MSI had been obtained, would have been pushed into cancer at the time of the initial study. And these are the patients that would have been found to be, or would have been pushed into the benign category, so they would have avoided further evaluation, further diagnostic testing. So significant impact on the predictive value. This is another way to look at it. Hit the slide one more time. So this is a waffle plot, or as I've learned, Michael. These are lung RADS patients of 2, 3, and 4A. This is from National Lung Cancer Screening Trial. All of these 348 patients had cancer, all the gray blocks, and every red block has a gray block underneath it. So this group, when they were first detected, a nodule detected, was kicked off. Their next intervention was a study 1 year later. This one was 6 months later, this was 3 months later. If at the time, retrospectively, if at the time of the initial nodule detection, you had applied Reveal, these people who would have been found to have cancer, that would have been added to it. These folks, so they would have avoided waiting a year with a cancer sitting in them. They would have avoided waiting 6 months, and these people would have avoided waiting 3 months. So significant change. Same thing with but flipped on benign. All the people in green would have been found to have, or strongly suggested that they had a benign condition and would have avoided further diagnostic testing or interventions or whatever was done to them. Did I cover that correctly, Michael?
That was great.
All right. Michael's the smart one in the group. Same thing, different way of looking at it. And the reason I'm really going to highlight, you could hit it twice, Ryan, if you would. This is the holy grail for surgical intervention. You're never going to get better than taking stuff out that's less than a centimeter. I mean, that's your survival rate of 90+%. If you take a look at the people that showed up in National Lung Cancer Screening Trial with a lung RADS 2, their risk of malignancy was 0.5% according to just the standard lung RADS classification. If you throw an MSI on them and it's 0.9, you're picking it up 36 times more effectively. Same thing for 3. So same data as the previous slide, just a different way of looking at it. But you're taking these folks that have malignancies and picking them up, you're upgrading them much more quickly at the point of the nodule. Next. And this one to me is particularly interesting. So go ahead and hit it one more time. When we as clinicians look at a nodule, we have all kinds of stuff we bring to the nodule. There's clinical experience, we look at the size, the way it's shaped, the lobe it's in, the way we had for breakfast that morning, but all those tangibles and intangibles we evaluate. If you break those down in a predictive model sense, this is the one that's most important is the size. Size matters in lung cancer. If post-evaluation you evaluate the impact of MSI, it accounts for about 50% of the predictive value of the whole situation. If you do it first, if the very first thing you do is apply an MSI to it, its predictive value is well over 95%. So again, very significant point of data. And in my mind, and there's no proof of this yet, one of the reasons why I look at this and go, I think this may become the primary communication tool about malignancies, lung cancers. Next. All right, so tracking. So you've got these nodules selected and detected. You've got all this data generated around them. So you're either going to have a bevy of 10,000 people, or you're going to figure out how to manage these people. And this is where Think Health came in. So MSI has become a component of the map. The issues really with tracking include making sure the data is airtight and making sure everybody involved in the care pathway is notified so they can act appropriately. PCP, patient, the lung nodule program, and this is what this does. In addition, it automates scheduling and follow-up. So the point is, you can take the FTEs that you've got, this is automatically being done, and they can now focus on patient management, not data entry. Next. This is what Think Health, specific to lung cancer screening, has provided. Next, hit the button. Automatic lung cancer screening, tracking incidental pulmonary nodules, and tracks pathology results. So we've taken historically two groups of nodules, lung cancer screening and incidentals, and put them together. You don't have to develop separate pathways for it. Second, it provides communication throughout the system without impacting radiology work. Last, and it'll also allow significant program analytics and track the follow-up. And obviously interventions, that's our job. But having put all this stuff in place, it makes interventions much more patient and data evaluation as opposed to data entry sensitive. Next. So in summary, this is what it looks like. You're running detection on all the scans. Stratification is applied at the point of nodule. It informs the next steps, which include tracking, intervention, and treat. Your tracking system is there not only to help guide your patients through in the appropriate pathway, but also to give you the ability to go back and look at your data. And finally, your interventions obviously are patient-focused, whether they're follow-up interventions or whatever. We gave this system a name, eLens, Early Lung Evaluation and Nodule Screening, for all lung cancer detection programs, increased detection, earlier, more accurate diagnosis, increased efficiency of patient management, reimbursement, which is huge, the program refinement. But I think there's another dimension to this, and that is that a lot of systems don't know exactly how to get these programs started. And I know that because I've dealt with a lot of them. And it's like, where do we start? Do we do this? Do we do that? One of the advantages of putting this system in place to begin with is it generates data that can guide your resource deployment. So instead of throwing 6 FTEs at a bunch of problems that you don't know exist, you have data that says, this is where we need to put people, this is where we need to put people we need an eye on, or something like that. So I think in addition to management benefit, this system also is good for construction of the programs. Next. On the surgeon level, and again, this was initially supposed to be targeting the surgeons, my operating on false positives rates is in the 9 to 13%. I'd love to have it to be 1% or 2%. You're always going to have some people that are mistaken for malignancies because you don't want to err on the other side. But this shifts that false positive into a much lower level. It's also stage shifting toward early stage cancer and a reduction in watching it. From a volume standpoint, it's hard for me to see how this would not increase volume because you're shifting the entire detection and management curve toward early stage lung cancer. That's it. So thank you very much.